Welcome, everyone. Thank you so much for joining us. We'll get started in about 5 minutes at 11:30 a.m. Eastern Time. All right. Welcome, everyone. Thank you so much for joining us for the fourth installment of LBDA's 2023 Community Webinar Series, Prescription for Hope, Using Palliative Care Concepts to Support Self-Management in Lewy Body Dementia. My name is Julia Wood, and I'm the Director of Professional and Community Education here at the Lewy Body Dementia Association. Throughout the remainder of 2023, we will be hosting a series of webinars on a variety of topics for people living with Lewy, their care partners, and community members. These topics have been selected based upon your feedback through many of our channels. Today's presentation is in collaboration with the International Neuropalliative Care Society. I will let our first presenter and president of the INPCS, I will let Dr. Neha Kramer tell you more about that in just a moment. Before I introduce our presenters, I'd like to tell you about the LBDA and the many resources that we have to support you and your family. The LBDA is a national nonprofit that was started by care partners 20 years ago, seeking answers and support in their journey with Lewy body dementia. We provide education via our website, downloadable materials, and our Mediflix and YouTube channels. You can call our Lewy line or join a live, virtual, or Facebook group from our support services. And we provide up-to-date information about research advances in LBD and encourage your participation in research through our Lewy Trial Tracker. Just a few housekeeping items before we get started. You are welcome to submit your questions anytime using the Q&A button on the bottom of the screen. Following the presentations, our presenters will answer questions for about 15 minutes. This presentation is being recorded and an email will be sent to those who registered in about 1 week with a link to the recording. You can also find the recordings for all of our webinars on our YouTube channel. So when you leave the webinar today, you'll also receive a brief survey that will ask for your feedback about our presentation. Please take a moment to complete that survey to help inform our content in the future. So without further ado, I would like to welcome Dr. Neha Kramer from the International Neuropalliative Care Society and LBDA's Rush University Center of Excellence. Dr. Kramer.
Thank you so much, Julia, for inviting us today to speak. We're really excited to talk to you. We have a great team today. We have Dr. Benzi Kluger, who's president of the International Neuropalliative Care Society and a neuropalliative care specialist in New York at the University of Rochester Medical Center. We have his colleague, Dr. Sue Ouellette, a neuropalliative care chaplain, also at University of Rochester. We have Sarah Chen, licensed social worker that I work with in Chicago at Rush University Medical Center. And we have Dr. Malenna Sumrall, who's also a former care partner and currently a fierce patient care partner advocate. Today, we'll be speaking to you about how to use palliative care concepts to really support self-management and Lewy body dementia. Our goal is so that you leave here with ideas about how to advocate on your journey with Lewy body and how to bring in palliative care to support you on this journey. I'm going to share my slides. Wonderful. Our objectives today are to define the role of palliative care, including hospice care and Lewy body dementia. We'll identify the pillars of palliative care and describe how they can be applied to self-management in Lewy body. We'll understand the role of members of the palliative care team. We'll name resources to help locate and advocate for palliative care services in your healthcare journey. And we'll hear firsthand experience from our LBD care partner, Dr. Malenna Sumrall, about how palliative care transformed her journey in caring for her loved one. So the way we've structured it is Dr. Sumrall will share her story in parts, and the story will unfold throughout our presentation today. So without further ado, I'll pass it on to Dr. Sumrall.
Hi, my name is Malenna Sumrall. I was my husband's care partner for the entire journey that we had through Parkinson's, which was the initial diagnosis. In the year 2000, I mentioned to my husband that there was a slight tremor in his little finger. He had noticed it also, and we both immediately thought Parkinson's because his dad had had something similar, although he was never diagnosed with that. When my husband went to see the doctor, of course, Parkinson's was confirmed, and we were as prepared probably as much as anybody can be to hear that, but still, it was a bit of a jolt. I told my husband, Ray, that it was going to be our disease, not just his. At the time of his diagnosis, he had been a social work professor at the University of Alabama for 30 years. Oops. I'm sorry. I'm sorry. I think two of us are trying to flip slides here. He had been a social work professor for 30 years. His whole career was dedicated to helping others. It was his passion, the thing that kept him vital. Ray's medical journey was quite varied, ranging from inadequate to superb. We started with a general neurologist whose knowledge of Parkinson's was very limited. He misdiagnosed symptoms and arbitrarily made modifications to the medications that Ray took. He would just have his nurse call us and tell us to pick up a prescription at the drugstore, and that was that. No exam prior to that. And of course, he was one of those who would never listen to anybody else, especially me. As the disease progressed, my husband began experiencing a whole host of symptoms. I'll mention two examples that were particularly distressing. He became manic on a dopamine agonist, and we couldn't get the doctor to change the medication because that was one of the reasons he was having those episodes. So we still had the manic episodes. He developed REM behavior disorder, and the general neurologist diagnosed that as restless legs. Therefore, that was not alleviated either. Instead, it continued, and so did the manic behavior until we could find a better doctor. In the meantime, I slept on the floor to stay safe. About 4 years after diagnosis, we found a movement disorder specialist, and that was a big improvement over what we had had previously. Appointments were a little bit hard to schedule, maybe 18 months to 2 years out, but still, symptoms were managed much better, and we were able to live our lives much as we had. In 2006, my husband was diagnosed with mild cognitive impairment. The impairment was significant enough that I knew I needed to give up my job to help him. I retired early and devoted my time to his needs, both in his profession and at home. While this was a better medical environment, still sometimes I felt unheard even there. In 2009, his diagnosis was revised to include dementia. We received that diagnosis not in a doctor's office, but in a letter with no details about what type of dementia it was or what to expect, and no one to help us absorb the news. I had been through Alzheimer's with my mother-in-law, my father, and to some extent my mother. The dementia I saw in my husband seemed different, but no one told me that it wasn't Alzheimer's, that it was Lewy body instead. Knowing that and having information about what to expect would have been so very helpful. Instead, I stayed confused and felt inadequate as a care partner. A year into that devastating diagnosis of dementia, my husband realized that the profession he loved for so many years was too much for him, that his cognitive decline was keeping him from doing his best, so he retired. When you're working, you have plenty of people around you who are important to you. When you retire, those relationships can become less powerful. When you add in a debilitating disease such as Parkinson's with Lewy body, you find that some relationships change drastically. For the person with the disease, the ability to get out and be with people is hampered, and difficulties with speech and cognition affect the ability to communicate. For the care partner, there's very little free time, but even if we manage to get out, we are most likely preoccupied with our partner's condition and our caring duties. As a result, we found that a lot of people that we called friends were simply just acquaintances, and we felt more and more isolated. This was the beginning of my grief journey. Watching my husband decline and losing contact with friends was very hard.
Hello, I'm Benzi Kluger. I'm a neuropalliative care specialist and the president of the International Neuropalliative Care Society. And I actually had the pleasure and honor of serving Malenna and her husband in my practice. So I'd like to talk to you about neuropalliative care, both as an approach to care, which is what I'm going to focus on, and then as a specialty, which Dr. Kramer will talk about more later. But I want to kind of demystify palliative care, and it really comes down to two big things. The first is, in a nutshell, that an illness like Lewy body dementia sucks. It causes multiple dimensions of suffering for patients and families. And most of these dimensions of suffering are things kind of similar to what you heard in Malenna's story, things that our medical system does not do a great job of attending to. So we do an okay job of attending to some physical symptoms, but even there, about half the time, things like pain and insomnia and constipation fall between the cracks. We do an okay job with anxiety and depression, but when we talk about having a normal reaction to a bad illness, such as grief and anger and frustration, again, things are often lacking. Spiritual and existential support, which goes beyond religious, and Dr. Ouellette will talk to you more about that, but talking about meaning and hope and identity, which are all big spiritual and existential issues that come up with such an illness. Financial concerns, worries, what's been called time toxicity, so the amount of time you spend with doctors, and then the social aspects of this, which Malenna also alluded to, social stigma, isolation, people dropping away. So there is a lot of suffering that comes about with an illness like Lewy body. The other big part of palliative care is that the need to enjoy life doesn't end with a serious illness. So we definitely want to make sure we address suffering, but we also don't want to lose sight of the fact that things like joy and meaning and connection and transcendence and love are still possible. And I believe this is a big part of palliative care. And this is also a big gap, I would say, in the support that we provide people, is that we don't acknowledge that these needs, these very human needs, still exist. And so one of the things that I think about with my team, but I think goes beyond specialist palliative care and is really part of this approach, is how do we find physical pleasure? How do we find emotional happiness? On the spiritual side, how do we reconnect with ourselves and find hope and serenity and maybe transcendence? Where do we find meaning? And I think very importantly is to not lose sight of the opportunity for connection and how precious that could be. I would say even more so when facing a very serious illness like Lewy body disease. So what palliative care is trying to bring these two things together. So the goal of palliative care is to improve the quality of life of patients and families by addressing sources of suffering and exploring opportunities for joy, hope, love, and meaning. And I think important in this definition is that we acknowledge that Lewy body disease doesn't just affect one person. It affects their partner, it affects their family. And so we want to provide support for everybody. And then we also acknowledge, and this is not any individual's fault, is that our healthcare system and the way care is set up, that we often don't address these issues probably as much as we could or should. And that's something that we are working on, and we'll talk about how you can be part of that change. So palliative care needs are present at diagnosis and often before, and they change over time. And I think Malenna's story, and probably a lot of you in the audience's experience is similar, as I can't tell you how many people with Lewy body related diseases had a traumatic experience around diagnosis, that they were misdiagnosed often several times, that the diagnosis itself was not presented in a way that was useful or with compassion, or was presented in a way where there was a lot of uncertainty and it was hard to act on. And so we really want to use this approach, this person and family-centered approach, right from the time of diagnosis. And we want to keep it in our back pocket throughout the course of the illness. A question I get a lot from both healthcare providers and patients as families is, when should palliative care start? And my answer is that it should start as soon as you know you have a serious illness. That doesn't mean you need to see a palliative care specialist, but it does mean that we need to bring in these ideas of that approach so that we can address the not just physical, but also the emotional and spiritual and logistical challenges and planning for the future right from the get-go, so that people have, the best chance of having a good journey with an awful illness. In an ideal world, palliative care would be integrated into all care from the diagnosis onwards. And this is something that we at the International Neuropalliative Care Society and the Lewy Body Disease Association and others are working on. So in an ideal world, your primary healthcare team, which could include a neurologist, internist, advanced practice providers, will be addressing basic communication needs. They'll answer your questions. They'll be able to screen and provide basic symptom management. And then they will be able to recognize and trigger referrals to others on the extended healthcare team for when more help is needed. And that could include seeing a social worker or mental health counselor or spiritual care or chaplain. It could include pain management, could include addressing other needs that come up. And then at some time in almost everybody's illness, there are times where specialist palliative care may come up. And that oftentimes happens well before the quote terminal phase of an illness. So there may be a time where you need extra specialist palliative care, and Dr. Kramer will talk to you about that. And there were also times the world mortality rate is flat at 100%. So I hate to be the person to break this news if you didn't know it, but we're all going to die, and we're all going to need help around that time, and our families are going to need help around that time. And that's really the goal of hospice, is to give people as much control and dignity and time at home during that very critical and difficult period of illness. So in the real world, what can we do right now? We have to advocate for ourselves. And this can mean, and we'll kind of go through, asking questions. It could mean as much as getting a second opinion or switching doctors. But we will give you some tips and tricks for doing this. And I would say right now is that after this webinar, you may know more about palliative care than your healthcare team. And so it may be the case that you're going to lead them into this palliative care approach rather than them leading you. And that's okay right now. Hopefully in the future, we don't need to do that. But for right now, I think that's kind of the current state of affairs. So one of the fundamental things with that idea is this concept that you are part of the healthcare team. This notion kind of came to me because I was doing some research projects where I was trying to change the behavior of physicians, and it is possible, but it's difficult. And as we were doing this, we recognized that patients and families were much more invested in changing care and improving care. And so what we started to do was to give patients and families the tools that they needed to ask the right questions and get the checklists, and they were able actually to get their physicians to do things way easier than I was able to do so. So you would be surprised actually of what you're able to do from the patient and family seat. I would also say that, and admit that it can be intimidating. And so it can take practice, and it is good to be prepared for your healthcare visits. There is research showing that activated and empowered patients and families do get better care. And you have opportunities to shape the care that you receive by the questions you come in and the way you approach your visits. So we're going to talk about how you can bring this palliative care skill set and tool set, how you can bring this approach into the care that you're receiving right now and today. So, and the first part is thinking about, before even getting to the doctor, of what can you do to reduce suffering? And using a palliative care approach, and this could be something, and actually these slides will be available to you, and you can go through these on your own and have a chance to journal and give this some thought. But the question would be is what are your sources of suffering? And the obvious one is that you have Lewy body disease, but what is really toughest about that to you? Some of the things when I ask people that question about what's toughest, sometimes it can be a symptom. Sometimes it's a loss of independence. Sometimes it's a loss of activities that bring joy. Sometimes it's changes in connections with people. So it's really digging deeper to think about the very specific things that are causing suffering. And then for each of those to think about what are the options for cure, coping, or compassion. So for cure, as an example, could be for something like REM behavior disorder. That can be for a lot of people very treatable. And so there may be a medication that can alleviate or make a symptom or an issue significantly better. There may also be opportunities for coping. And that could be that maybe there is a symptom that we can't get rid of, but we can find ways that it can be easier for you to live with that. And there are, counselors, occupational therapists, and physical therapists, and speech therapists who may be able to help along those lines. And then lastly, there may be things that we just have to live with. In which case I would say that compassion is going to be most important. And Dr. Ouellette and the chaplains on our team are great with helping people not only finding compassion for themselves, but finding ways to feel connected to others who are going through the same circumstances. And then we can flip things around and look at what are the opportunities right now for increasing joy. And questions that I ask in my clinic, and I think you can ask yourself and journal and talk about with your family, could include things like what strengths, values, loves, and joys do you carry into this illness? How have you made it through tough times in the past? How can you stay connected to these important parts of who you are in your life and your current situation? And lastly, are there ways to adopt or adapt to stay connected, or possibly even new opportunities to explore? I've actually just recently had a family who made the decision, knowing that the time they have right now is so precious, that they were going to follow their dream to get an RV and travel. And I routinely see them on Zoom in different states. They've gone down Highway 66. So there's no better time than the present to follow those opportunities, particularly if you have an illness like Lewy body disease. Lastly is finding your people. And so who in the personal and healthcare community can you turn to share your suffering and celebrate your joy and find support? And on the healthcare side, this could include doctors, but also in the palliative care is very much a team-based sport. And so nurses, social workers, chaplains, and therapists can all potentially help with finding ways to cure and to cope and find compassion. And on the personal side, friends, family, spiritual community, neighbors, and support groups are great. And I would give you encouragement that one of the joys really of the work that I do is just how not only willing, but how much people enjoy being able to give to others who can use their help. And that exchange, which often involves a little bit of difficulty for the people receiving help and a practice of grace, can really be a beautiful thing. And giving people the opportunity to support you, can be a beautiful gift to them as well. With the Parkinson's Foundation, we developed 5 pillars to really make palliative care concrete. We wanted to make it measurable and memorable and actionable so that we can get centers of excellence to be able to deliver this care. And for all of these pillars, there are things that you can do, you and your family can do to try to improve the care that you're getting. So these pillars are non-motor symptoms, which could include things like pain and confusion and sleep. And the skill that you can have as an individual is being able to set the agenda for your visits and bringing in a symptom checklist. On the side of emotional and spiritual support, you can go outside of the medical model and find counseling and peer support. When it comes to preparing for the future and this feeling that you're feeling your way forward one way at a time, and one step at a time in the dark, you can start important conversations. And there are tools online, and I have some that I'll share with you of question prompt lists that can help you ask your doctors the right questions so that you can get the answers that you need. Regarding family support, you can ask what you need, and we have a caregiver checklist. And for specialist palliative care and hospice, it's okay to get an extra layer of support, and we'll talk later in this talk about how to get referrals to resources in your community for palliative care and for hospice. This is just an example of things that you might consider on the checklist for non-motor symptoms. Other things on the 5 pillars, other people on our team are going to go over in more detail, but I just wanted to put this out there for you. And then Neha will go into this, but some of the things just to set the stage that palliative care can offer include more help with chronic symptoms, more guidance, more assistance around challenging decisions. A lot of the things that you're going to hear in Malenna's story are things where palliative and specialist care can be helpful. And so with that, I will turn things back to Malenna and welcome you to read these extra materials and slides at your convenience.
Well, I must say that very first day that we met Dr. Kluger in his clinic, that was the day he became my hero. By 2014, we were late in the disease journey. This is my husband soon after we moved to Colorado, and you can see that he's in a power chair. We had a son there that could help, and that was the reason we moved. By this time, I was exhausted, and I felt that I was losing my husband a millimeter at a time. We had a referral to the neurology department at the University of Colorado, and by the luck of the draw, guess who we got? Yes, Dr. Kluger. Our first appointment with Dr. Kluger, he spent a lot of time collecting history and assessing my husband, but he was also assessing me. He is the only doctor through 14 years of appointments who ever asked me how I was. My reply was overwhelmed. And it was the first time I'd ever felt comfortable saying that. Based on my husband's condition and my need for help, Dr. Kluger recommended that future appointments be with the Neuropalliative Care team. We had no idea what that was, but it sounded terrific, so we jumped at the chance. The palliative care team consisted of Dr. Kluger, a social worker, a chaplain, and a nurse. Our appointments with them were eye-opening, refreshing, and comforting. Each of them really listened to both my husband and to me, and they assured us that all our concerns were being addressed. We were able to have 2 appointments with the team before we moved on to the next level of care, which was in-home palliative care. That transition and the wonderful experience we had with the social worker and the chaplain will be highlighted later in this presentation.
Hi, I'm Sarah Mitchell-Chen. I'm a licensed clinical social worker at Rush University Medical Center in Chicago, and I'm going to speak about the role of social work on the team. And so social work can help address some of the non-medical barriers to care, health, and well-being through engagement, care planning, and goal attainment. And what does that actually translate to look like? It looks like whatever the questions or concerns are that either are identified in the visit during the conversation with the physician and team, or the questions that families and care partners and patients bring into the visits, social work can help kind of get to the bottom of what's going on, or what's at the root of some of these questions or concerns, and begin to help with that navigation. Or problem solving or advocacy. Is it that we're needing additional hours or more support in the home? Is that we're trying to understand how to navigate benefits through insurance or other programs that may be able to increase the quality of care that someone is receiving, or the support that their patient or care partner are receiving? And so when you think about who all is on your team, several people in this conversation so far have talked about building your care team. And it's important to surround yourself with members from various professions, disciplines, and training backgrounds, because over time your needs may change. And so this team may ebb and flow around who are the most active players on the team. But it's really important to think about who have you had experience with, who is able to help support you and your loved ones and family. One of the most frequent questions we hear is, how do you find these team members? How do you find someone that is familiar with Lewy body dementia or Parkinson's disease dementia? These can come from referrals from your specialist office. It also may come from the disease-specific foundation like LBDA. But most often, where you're going to find referrals for folks in the community is through word of mouth, through other patients and care partners. And you may connect to them through local support groups or events that are hosted. And you can find a physical therapist or an occupational therapist who's more familiar with neurodegenerative diseases. And so often people think about, what might your care team include? Who might be the key players? And of course, at the center of the care team are going to be the patients and their care partners. But then you may think about physical and occupational or speech therapy. You might think about a dietitian if we have to think about modifying the consistency of the food. We may think about a support group or a therapist or a psychiatrist. And this might be for the patient, but it also could be for the care partner as well. We really see these 2 members of the team being such a critical role. And so we want to be supporting care partners, like Dr. Kluger mentioned, just as much as we're supporting patients. So it may be that the care partner is connected to a support group or a therapist. We also don't want to miss out on the opportunity that family and friends may be able, the support they may be able to offer. Sometimes people aren't sure how they can be supportive, and so, but are more than willing to help. And so it's thinking about then, how do we leverage those resources? Can your neighbor or friend come and sit with your loved one for a few hours while you run to the store or go out to lunch with some girlfriends to get a break? So it's, these are examples of who might be on your care team, but this is not an exhaustive list, so get creative. We often get a question of when would it be a good time to talk to a social worker? And now there's no time like the present. Some of the key moments that might be helpful is, like Dr. Kluger mentioned, at the time of diagnosis, it can be pretty overwhelming. There can be a lot of new information coming at us. There can be a lot to sort through. And a social worker can potentially help you sit down and figure out, where do we start? What are the biggest priorities right now? And how do we begin to chip away at some of those needs? And the social worker may not need to be involved with all of it, and they may be able to help you kind of prioritize and then periodically check back in. Another time might be if or when there's change in symptoms or a need for increased care. And again, we'll touch on this a little bit later in my presentation, but it's beginning to think about, how do we navigate our way through? And this last one may feel a little odd, but in a season of calm, when you can begin to plan or think about what are going to be some of the things on the horizon, and how do we begin to set some things up so that those will be a little less overwhelming, or we'll feel a little more in control when those needs come along. And so this list is not an exhaustive list. It's more to get you thinking about, what are some of the questions you might bring to a social worker or bring to your clinic appointment with your specialist and say, is there a social worker on the team that I can get connected to? You may not have been connected with the social worker yet. You can always ask if there's one available in the community or in the health system you're connected with. Otherwise, there's support through the Lewy line or through community organizations. There's lots of social workers embedded in the community in area senior centers or disability support programs. And I'll give you a resource about how you might be able to access those in your area at the end of my talk. But those can be a huge resource to help you figure out how to navigate your way through. One of the things from this list I want to highlight that I'm going to come back to is we want to sometimes think about a crisis plan. And that may not be the first thing that comes to mind when you think about how you can leverage a social worker to help think through needs. But planning, that can be part of what we think about when we're planning for the future. And so, like I said, what does planning for the future look like? Some of that anticipatory planning, it's so beneficial to both patients and their care partners. And so it's creating a space for hard conversations or uncomfortable conversations about maybe wishes and preferences. We may not have had these conversations before, and people may be wondering, what would my loved one want? Or how do we bring in care? What would that care look like? What is my loved one comfortable with? It allows opportunities for these uncomfortable questions, and it allows for shared decision-making. So when we have these conversations early, it allows care partners to then know if down the road I need to make a decision, it's been informed by this conversation with my loved one. I'm not trying to guess about what I think they might want, because we've been able to have these conversations ahead of time. And we know that dementia is a part of this illness of Lewy body dementia or Parkinson's disease dementia. It's in the name. So we want to try to have these conversations early so that our patients and loved ones can be a part of these conversations and tell us what they want. Having this conversation, it's uncomfortable, but it's a gift that we can give our loved ones. And it's something that we can all do together. It doesn't need to necessarily be focused on the patient. It can be the patient and care partner having this conversation together with their family about what everyone would want. And then we can put them away. We know we've had the conversations. We know where people stand. We periodically revisit it, but it's not something that we have to have at every dinner, have the same conversation over and over again. We also think about planning ahead as a way, like I mentioned, to do a little bit of crisis planning. So we think about what would we do in the event that our care partner was ill, if they needed to have a planned or unplanned surgery or trip to the hospital. Is there a neighbor that could come sit? We want to alleviate any additional stress on an already stressful situation. And we also want care partners to feel like they're able to go and take care of themselves. We recently had a patient in clinic whose care partner told us they delayed their own treatment because they were concerned about what their loved one would do without them there. And we don't want you to be scrambling to come up with a plan in that moment. Is there a neighbor or neighbors that might be willing to sit with your loved one until family who maybe lives a little further away is able to get there? Or is the agency that you bring in who's already involved able to provide some additional caregiving support while you are away? So you know your loved one is taken care of, and you as a care partner can go and tend to your own needs, because we know that your loved one is doing as well as they're doing because of all of the work that the care partner is doing behind the scenes to continue to support that. And we see that, and we want to make sure that this is another extension of you being able to take care of yourself. We also think about advanced directives and where are those documents? For many of us, myself included, they're probably someplace safe, and that safe place is put away. And in the event of a crisis, we don't want to have to go digging around to find them in that safe place. We want them to be easily accessible. And that might mean that they're shared electronically in an email with family and close friends. It might mean that they're on file with the physician and the local hospital where you might go in the event of an emergency. It also might mean that you have a copy on the side of the freezer so you can grab and go, or it's a copy is in the glove box in the car. If you want to be an overachiever, you also might include a list of medications, physicians who are included, and any other pertinent medical conditions. We know that medication dosages are changed regularly, and in the event of a crisis, again, that may not be the time to try to keep track of, oh shoot, which dosage is my loved one taking? Our brains are going a million miles a minute. So thinking about what are some things we can put in place ahead of time to make a crisis a little easier. It's called a crisis for a reason. Everything's all up in the air. And so if little incremental things that we can do to make life a little easier go so far. So when you think about what might be helpful, all of these are going to be hyperlinked so you can explore them later. But the Disability Information Resource and the Elder Care Locator are both federal programs. The Disability Resource is for those 60 and under. The Elder Care Locator is for 60 and over. You can search by your zip code and explore what is available in your community. There may be a little bit of overlap. And then if you're a veteran or someone in your immediate family or is a veteran, you may want to also take advantage of what resources they have to offer. If you want to learn more about thinking about how you bring in additional help at home, I recently recorded a webinar for the International Neuropalliative Care Society that will be up on their website later next month. And I go a little further into thinking about what are some additional things that can be helpful, or how do you explore resources. And then I know that Julia mentioned all of these at the top, but I would be remiss if I didn't point them out again. Just utilize the resources that are available through the LBDA, and they can, again, help you point you into the direction of how you find resources and things in the community. and how you think through some of these things going forward.
Listening to Sarah makes me wish she could have been part of our team from day one. That was wonderful. We were no strangers to the field of social work. My husband had spent more than 50 years as a social worker, and because I had to help him with his work as his condition worsened, I had limited unofficial experience in the field for almost 5 years before he retired. In spite of that, however, it never occurred to us to reach out to a social worker for help. During our first palliative care appointment, we met the social worker that was part of the team. She walked in, introduced herself, and asked Greg what kind of work he did. When he said he was a retired social work professor, she looked up at him and she said, "Oh, am I doing it right?" And we both laughed, and she smiled. That immediately lightened the mood in the room, making both of us feel more at ease. She asked about accessibility in the house, and then talked about whether or not we had stairs to negotiate. Well, we did a little bit. And so she looked at me and said, "You need to get a ramp." And she gave me a look that told me I better obey that. She stressed that it was not only safer for Ray, but it was safer for me as well. Because we were new in the area, she knew I had no idea about what resources were available in the Denver area. So she helped me with that also. The profession of social work is not well understood by the general public. People have no idea how helpful they can be in so many various ways. They are well trained in their area of specialty and have the capacity to perceive needs and attitudes in a way that allows them to communicate effectively. If our social worker had come into the room with a sympathetic, "Oh, I'm so sorry for you," kind of demeanor, I might have tuned her out. I didn't need to feel worse than I already did. Instead, she lifted the heaviness and engaged us in a way that was totally unexpected. I looked forward to our visits with her. I would tell anyone who has a referral to a social worker, do it. And by the way, that social worker is a friend of mine. We've stayed in touch over the years, and I consider her a very, very good friend.
Hello, I am Sue Ouellette. I am the Neuropalliative Care Chaplain at the University of Rochester Medical Center, where I have the distinct pleasure to work with Dr. Kluger. And I'd like to spend a few moments today talking about the role of spirituality in meeting the needs of persons with Lewy body dementia and their family. Oops, I got 2 slides. The first question to be addressed, I think, is what is spiritual care? And the immediate answer I would give is misunderstood. Very often people think of spiritual care as religious care of some kind. And while that may be a small part of what some chaplains may bring to the table, spirituality is much bigger than that and much more encompassing of our basic human needs. So this definition by Dr. Christina Polchowski is one that I think speaks very well to the meaning of spirituality as a dynamic and intrinsic aspect of humanity through which we seek ultimate meaning, purpose, and transcendence. In other words, how we try to figure things out, how we make sense out of our world and what's happening to us. And it is also the frame through which we experience relationships to ourselves, our family, our friends, our community, our society, nature, and that which is significant, important, or even sacred to us. And we express it through our beliefs, our values, our traditions, and our practices. So spirituality is something that everyone shares, even though they may or may not have any religious affiliation. And for chaplaincy services, that really isn't a consideration. chaplains see people of all different faiths and no faith at all. Some of the issues that we might consider under the rubric of spiritual considerations are ones that you may be familiar with. These are issues or considerations that people have with Lewy body dementia, but they also sometimes surface for family members in one way or another. And we'll talk more about that as we go on. So body image changes, and that's a major concern for many people. I have many patients who tell me that they don't want to go places or be out in public because they think they look different and feel that people might be judging them in some way or looking at them. Disease affects our identity very much. It affects our sense of who we are as a person who is an agent in this world and able to accomplish things and act on whatever it might be of concern for us at the time. The fear of being a burden is a huge one that I hear from, I would almost say, the majority of my patients. Loss and grief. There is very real grief involved in Lewy body dementia and other similar conditions. Grief at the loss of dreams that are core level dreams for us, dreams that we have about what our life will look like as we age, dreams of things that we want to do once we finally have the time and resources to do it. Another spiritual consideration is that serious disease brings us to the point of confronting our mortality, not just for the patient, but for the family members as well. Spiritual distress is a real concern as well. And spiritual distress has to be with times that our spiritual beliefs and the way we're feeling at the time don't quite mesh. We may have, for example, had very strong beliefs and been a strong participant in some form of religion or some belief system. And the experiences that we're having, the way that we're feeling, aren't consistent with what we've always believed. And that leads to a kind of distress that's very deep within the soul. And just the idea that spirituality and well-being are very much connected. So providing services that allow people to explore their spiritual beliefs, their spiritual wellness, are critical to their well-being. So what might a chaplain do as part of this process, or anyone else who might be attending to spiritual needs? By the way, that's not the exclusive province of the chaplain. Every member of the team that you're working with ought to have spiritual needs and considerations in mind. So answering questions like, why me? I hear that over and over again. What did I do to deserve this? What's the reason for this? Helping to resolve spiritual distress when those beliefs and your feelings don't quite match. Something that Dr. Kluger mentioned that I think is so critical is helping people to find hope, meaning, and beauty and awe, even or especially in the midst of grief and loss. I think there has to be a balance. The grief and the loss are real and constant. We can't ignore them. It would be a disservice to do so. But we can't stop there either or live there. Adding, how do you find meaning? How do you find beauty? How do you find experiences that help you to make sense of this is an important part of the work that we do in spirituality. We help patients sometimes reframe their illness or see it in a different way or refocus on what's really important in their life. I often work with people who have been artists, musicians, or artists in the sense of working with clay or paint. And they're no longer able to do that. They don't have the dexterity. So often talking about how can you be an artist if your hands don't work is an important way of reframing or refocusing. Just helping to integrate illness into the patient's way of making sense of the world and allowing their pain to be witnessed, allowing their pain to be heard, I think is absolutely critical. So what does a chaplain do? A chaplain conducts an assessment to find out what spiritual needs are. A chaplain addresses those needs and concerns. Chaplains often refer to clergy members in the community to offer specific religious care, baptisms, end-of-life care, confessions of one sort or another. Those are referred out to the religious professional who represents the faith tradition of the patient. We help people clarify their values. What's important to you in this illness? What are the parts of the illness, the parts of life that illness can't take away from you? How do you want to approach end of life when that time comes? We look at spiritual distress. We've talked about that before. We look at issues like meaningless, fear of death is common, hopelessness, easy place to get to emotionally, feeling like, well, this is not going to get better. It's hopeless and it doesn't need to be. And identity loss. And then providing spiritual care for family members and care partners is a very important part of the job of chaplains, just as it is for everyone else on the team who's talked about how important care partners are. We help staff members who are coping with spiritual or existential issues, and we refer to mental health professionals when there is a need to diagnose or treat a mental illness of some kind. So I wanted to get into a little bit of a different area here for just a few minutes and really look at what is caregiver burnout here? What are we talking about when we're talking about the existential and spiritual battles that caregivers face every day? And I feel a bit guilty giving this presentation because I know there's many caregivers that are watching this now or will be watching it. And you can address this far better than I, but the quote is like living a 36-hour day, mental and physical, emotional exhaustion, fatigue, decreased motivation, a lack of empathy towards others. We use up our empathy if it's not replenished, and that's so important. Exhaustion, depersonalization, and reduced personal accomplishment are all features that may sound very familiar to you. Some of the signs that you might want to keep an eye out for if you are a care partner or if you are a loved one of a care partner or someone who cares about a person who's caring for another. The physical burdens are very real. Fatigue, sleep problems, decreased strength. The psychological burdens, irritability, anger, depression, very common. Social withdrawal and isolation. Loss of intimacy, and that not only physical intimacy, but emotional intimacy. And the financial burdens, of course, that come with loss of employment, caregiving expenses, and many other sources. And moving towards wrapping up here, to emphasize the importance of self-care for all caregivers, planning daily and weekly activities that you enjoy, so important. Your well-being may feel like there's no time for it whatsoever, and yet the old oxygen mask theory that they announce on the airplane when you get on, if we can't care for ourselves, it's very difficult to care for those who depend upon us. Practice the activities that ground you. Take time to meditate, to practice deep breathing, to practice relaxation techniques. Reach out to others. None of us can do this alone. Share your feelings with other people. Reach out for help if you're facing serious burnout or depression. Speak with your physician, social worker, chaplain, and most importantly, care for your own needs so that you can care for the needs of those you love. Places to find support, caregiver support groups, we've all mentioned, peer mentoring programs, churches, synagogues, mosques, other places of spiritual connection, and private and public providers of counseling or therapy or psychology or psychiatry. And psychologytoday.com there is a wonderful tool to use to search for a therapist in your area. You can put in all the qualifications that you want, their location, whether you care about gender, whether you care about a particular technique, the experience they've had with the older people, whatever, and it will point you in the right direction. And some resources for self-care to wrap up here. Kristen Neff has a website called self-compassion.com. There's a wonderful caregiver meditation on there, number of meditations, lots of tips. I highly recommend it. University of California at Los Angeles has a mindfulness awareness research center that has free meditations on it that you can join. The Mindfulness and Health Institute at Brown University, run by John Kabat-Zinn, has free meditations where people from all around the world join, some as short as 15 minutes. Maybe you can fit one in. Tara Brock is a Buddhist meditation teacher who has a website with many free meditations. And there are, of course, all of the commercial mindfulness applications that you can take advantage of simply by going to the App Store on your phones. Our hope is just that you will realize that spirituality is important and that there are resources available to you, and take advantage of them.
I'd just like to emphasize what Dr. Ouellette was talking about in terms of self-care. How many times have we gone to the doctor's appointments with our loved one and they say, well, and like in Dr. Kluger's case, how are you? Just a simple question. And oftentimes we'll just say, oh, I'm fine, even though we're probably ready to strangle the next person that says the wrong word to us. We've got to get over that and learn to speak up and talk about the things that are really deep down bothering us too, because that's how we get better at caring for our loved ones. The two pictures here sort of represent the two sides of my husband, in his profession and how important that was to him, and then just in getting outdoors and enjoying life. Before he became a social worker, he earned a Master's of Divinity degree. And yet, like with the social work, we never even thought about trying to connect with a chaplain of any sort to help us through this journey. By the time we moved to Colorado, my husband had lost his much-loved profession, and he was quite physically disabled, and he no longer had the capacity to concentrate on any mental activity. When we met the chaplain for the first time, he immediately picked up on how hard those losses were for Ray, that he had experienced the change from being a motivated, productive, influential person to someone without a purpose. The chaplain conversed with my husband at length about finding meaning in other areas and made great suggestions. It did make Ray feel better, and it provided me with insights I had overlooked and with ideas for helping Ray overcome his feelings of uselessness and of being a burden. Chaplains, as part of the palliative care team, like social workers, are misunderstood. They have the ability, like social workers, to read the patients and care partners and to respond accordingly to the needs that they see. People who need reassurance from scripture and prayer can receive that. People who are less involved in religion but need spiritual or existential issues addressed can receive that outside the context of religion. They are a calming, reassuring influence that is much needed as we find ourselves more and more difficult situations.
I'm Neha Kramer, and I'll be talking about specialist palliative care and the transition to hospice. So we talked about, Dr. Kluger talked about palliative care as an approach, and he mentioned that all providers should be providing or practicing basic palliative care skills. So that includes your internist, your neurologist, but sometimes you need a palliative care specialist, someone who is more formally trained in palliative care. And so how can a palliative care specialist help you? We've talked about most of these things: coping with the diagnosis and changes along the way, treating symptoms that affect your function and quality of life, coordinating care throughout your journey, receiving a roadmap of what to expect, talking through tough decisions that may lie ahead. For example, is it safe to continue driving? What are the benefits and risks of feeding tubes? Should we be considering a transition to nursing facility or alternate care arrangement? What about do not resuscitate orders? Palliative care specialists can also help you connect to the things that bring you meaning, joy, purpose. It can help you relieve burdens on the family, understand your wishes and priorities, avoid inappropriate prolongation of the dying process, and give you a sense of control. And for care partners, a palliative care specialist can help you elicit and honor your loved one's wishes. They can help hear you, see you, walk alongside you on this journey, give you permission and encouragement to prioritize your own needs, connect you to support assistance at home, and again, talk through some of those tough decisions. So how do you request a palliative care referral? You can request one for your neurologist, from your neurologist or your internist. If there is no outpatient palliative care clinic, you can consider referral to a palliative care provider at another institution in your state, and even consider a telemedicine visit if it's a far distance. You can also consider referral to palliative care services in your community, either through hospice agencies or home health agencies offer home palliative services. So they actually come to your residence and do visits there. And as Dr. Kluger mentioned, you have to upskill your neurology team sometimes. You bring the questions and the checklist and drive the agenda for your visit. And if you hear from your neurologist or another provider that you don't need palliative care or you're not ready for that yet, be prepared to educate them that palliative care can start at the time of diagnosis, and it's more than just end-of-life care. So this is just a diagram similar to what Dr. Kluger had shown before, is that it starts at diagnosis alongside curative and life-prolonging care, and the palliative care needs fluctuate over time. And generally, palliative care needs can increase as disease progresses, and then will culminate in hospice care. So how do you request a palliative care, or when do you request a palliative care referral in the hospital? You might consider requesting one when you need support to help come to terms with a new or worsening condition. Perhaps being in the hospital has resulted in being more deconditioned, needing more help at home. Perhaps there's more difficult symptoms that have come up along the way. Oftentimes there's more care that's needed and need to be coordinated. And if you want to have a conversation about ensuring that the treatment plans match your goals, a palliative care referral is often a good place to start. If there is not a palliative care team in the hospital, you can request to speak to the social worker, the case manager, or a chaplain in the hospital. And so this is just to also show that hospice care falls under a larger umbrella of palliative care. So all of hospice is palliative care, but not all of palliative care is hospice. And notice on this chart that hospice is towards the final stages and then extending through bereavement. So oftentimes the question comes up, when is the right time for hospice? And I would recommend considering hospice when you're nearing the end of your life and you would like to prioritize time with family out of the hospital. A good question to ask yourself might be, do I want to manage the next crisis at home? And common crises could be infections or a fall, severe constipation, or sudden change in mental status. How do you want to manage this? Where do you want to manage it? And you might want to consider hospice when you feel you could benefit from an extra layer of intensive support at home. Traditionally, we think of hospice as someone being eligible in their final 6 months of life. However, with Lewy body dementia, it's very hard to predict how much time remains. We're oftentimes surprised in both directions. So rather than thinking about how much time is left, really thinking about hospice based on your needs and goals of care. Sometimes the questions come up of what does hospice offer and how is it different than palliative care? The goals are the same, improving your quality of life. We talked a little bit about when hospice is appropriate. Treatments that are offered in hospice are interventions that promote comfort. That is the primary goal. So medications that manage pain, anxiety, agitation, hallucinations, constipation, other symptoms that can be uncomfortable. Interventions like oral antibiotics for infections, because when there is an infection, oftentimes some of the Lewy symptoms can get worse. And so certainly treating the infection can promote comfort. Again, oral antibiotics may be offered. It's unlikely that IV antibiotics will. Many of your Lewy body medications that promote comfort will and can be continued. We'll talk a little bit more about this. Occasionally, some basic diagnostic testing is done, like urine samples and basic blood draws. However, there are limits to hospice, and particularly because hospice, they're on a very tight budget. And so they will not provide typically, and there's always exceptions, but they typically will not provide diagnostic imaging like chest x-rays or extensive blood work. Rehabilitative physical occupational speech therapy is generally not part of hospice care. They may have therapists that offer a single visit, really with the goal of promoting safety or comfort. So it might be a safety assessment in the home, but unlikely there will be repeated visits. Medications that don't promote comfort are often not covered or continued. So things like cholesterol medications, some heart medications, vitamins, and supplements. And really oftentimes as swallowing becomes harder, pills can also become burdensome. And so it is helpful to often think about what's the purpose of this medication and does it really make sense now at this phase of my illness? Medications that are not on the hospice formulary would not be covered. So oftentimes these are the expensive or newer medications, definitely important to acquire ahead, and we'll talk a little bit more. Hospitalizations are not covered in hospice. Just remember that you're not stuck in hospice. If there comes a time where you change your mind and you say, actually, I do want to go to the hospital, you can always revoke hospice services and re-enroll at a later time if that's still within your goals of care. And 24/7 custodial care is not offered, meaning that there isn't a caregiver in the home 24/7 that is covered by hospice. But there is 24/7 support lines where you can call, and if you have any questions, if challenging symptoms come up, you have a nurse that you talk to, so it avoids having to go to the emergency department. And if someone needs to come to the home for a visit after hours, hospice provides that. So where is hospice provided? Anywhere you call home. It might be your own home, it might be a nursing facility, it might even be in a hospital, depending on the level of care that's needed. Who's on the hospice team? It's usually the same members as the palliative care team: physicians, nurses, social workers, chaplains. It also includes home health aides, and this can be very helpful for baths and wound care. And sometimes volunteers and dietitians are also part of the hospice team. This varies by the hospice agency. Whereas a palliative care team may offer visits every 1 to 3 months, depending on availability typically, hospice care offers several visits a week, oftentimes a nursing visit 1 to 2 times per week, a home health aide 1 to 2 times per week, a social work once per week. If that feels too much, you can always scale back. So it's always depending on need and comfort. There's also different levels of care that hospice provides. We just talked about the routine home care, which is several visits a week. If there's difficult symptoms that are hard to manage at home, the nurse can come to the house and provide continuous care for up to 8 hours. If the symptoms cannot be managed at home with aggressive care, for example, if IV medications are needed or daily medication changes or 24/7 nursing care is needed, there's inpatient hospice facilities that can be provided. Hospice also provides respite care for 5 days consecutive. So if you as a care partner need a break or would like to leave town for a certain event, you can arrange respite care in advance where your loved one can go to a facility for a few days or go to an inpatient facility and be cared for while you're able to take that well-deserved break that you need. Hospice also provides basic home medical equipment like a hospital bed, bedside commode, oxygen. They can deliver within 24 hours often. They often provide a lot of supplies such as wound care or incontinence supplies. This can help save a lot of money. Hospice will provide bereavement services for up to 13 months, which can be very helpful. And hospice can be covered by Medicare Part A, Medicaid, private health insurance. So let's bust some hospice myths. Some people think that hospice care is for the imminently dying, but actually hospice care, people can be in hospice for several months or even longer. So if you survive longer than 6 months, hospice services can be extended as long as there is some decline in function that is demonstrated. And in fact, the longer you're in hospice, the more you can benefit. You can receive respite services more than one time. You can develop a trusting relationship with the providers. And that way they can be there for you at a real time of need. Hospice care does not accelerate death. Oftentimes that's a myth that once hospice starts, the morphine drip starts and not much time is left. And that's not true. There are studies in other conditions that have shown that some people survive longer with hospice than without. That's been demonstrated in heart failure. So really, hospice care is not giving up. It's about optimizing the quality of life for whatever time is left. And it regards dying as a normal process. You do not have to have do not resuscitate orders to enroll in hospice. Of course, that is something that will be addressed along the journey. And as we talked about before, all of your medications will not be discontinued, but be prepared to minimize some of them because hospice budgets are limited and because of the pill burden. And as we talked about before, hospice care does not include 24/7 care. So how can you advocate for yourself in the hospice process? You have the opportunity to interview various hospice agencies in your area. Some of the questions you might consider asking would be, what specifically do your services look like? How do you manage a crisis after hours? Do you have a full-time physician on staff who can be reached for emergencies after hours? Are you a for-profit or nonprofit business? Which team members are on your team and how often can you come visit? What is your experience with Lewy body patients and dealing with severe delirium and hallucinations? Ask whether the hospice agency will communicate with your referring physician, your neurologist, your internist, whether they have an inpatient unit in the event that the symptoms cannot be adequately managed at home, and whether they'll cover your meds. So it's important to discuss with your neurologist which medications should be continued and which can be discontinued. You may need to educate your hospice providers on LBD. They may not know much. So you may need to tell them which medications need to be voided, like Haldol. You may need to advocate for the meds to keep. They may be less familiar with some of these meds. So it's important to talk to them about how the medication promotes comfort and improves quality of life. Maybe talk about what happens when the medication is missed or discontinued, or a refill is filled late. What happens, or what happened, what was the improvement when the medication was started? If a medication is not covered, ask your neurologist whether there are alternatives that can be recommended. You can also ask the hospice agency if they have a similar medication on their formulary. You can fill a 90-day supply before enrolling in hospice, or you can interview another hospice agency and shop around. If continuing therapies like physical, occupational, and speech therapy are important to you, and you feel like you're still benefiting from them, you can self-pay. You can consider hiring therapy students, which may bring down the cost some. You can ask your neurologist to be on the hospice plan of care, either as a consulting or an attending provider. This way they stay in the loop and they can help educate other hospice providers also about the disease. And if you receive Botox for drooling or for spasms or dystonia, you can get the Botox before starting in hospice because it won't be covered. So you may want to consider getting it right before so you can benefit as much as you can. So here are some resources that you can look at later.
Soon after moving to Colorado, there were two occasions that required my husband to be hospitalized at local hospitals, not where Dr. Kluger practiced. Both were terrible experiences. There was no such thing as palliative care in either place. Both my husband and I were traumatized by these visits. I was determined to avoid hospitals after that, unless Dr. Kluger could be involved. That, along with my husband's decline, convinced the team at our second palliative care appointment that it was time for us to have in-home palliative care. Again, we had no idea what that was, but we were pleased that there was another level of care. With the in-home palliative care, we had a nurse practitioner who came once a month. We also had access to a social worker and a spiritual counselor as needed. The nurse spent a lot of time with both me and my husband and would review the criteria for hospice. And each time she would explain why we didn't quite qualify. I always felt that she was trying her best to help us get hospice care. One of the advantages of the in-home palliative care was having a 24/7 line that I could call when I had questions or concerns. Remember, I'm trying to keep my husband out of the hospital. One day, my husband was completely zoned out and didn't know who I was. That was the first time that had ever happened. I asked him, "Who am I?" several times, but he could not say my name. Finally, he said, "You are my lovely wife." This was new and frightening, so I called the agency, and because of that episode, it was decided that he was eligible for hospice care. Hospice was a huge relief for me. We had a nurse and a personal care assistant who came multiple times a week. We had access to a social worker and spiritual counselor again, and I could have had those respite days if I had wanted them, but I knew it would have involved placing my husband somewhere outside the home, and that would be too hard on him and probably on me as well. Although my husband was declining steadily physically, his mental decline was variable. He could be his bright, wonderful self one day and then completely out of it the next. One day, a day that seemed much like many others, the hospice nurse examined him and said I needed to get him in bed immediately. I said, what? Why? Just the day before, he was himself, talking and laughing, but she saw the signs. I put him to bed and started giving him the hospice drugs, and by early the next morning, he was gone. With this support, my husband was allowed to die at home, which was very important to both of us. I'll close my talk with a little thing here that I want to mention. On a recent episode of Finding Your Roots, one of the guests was Van Jones. It was a powerful episode and included a quote from Van Jones that really hit home. He said, "You die twice. You die when your body dies, and then you die the last time somebody says your name." I will continue to say the name of my brilliant, kind, and loving husband, who dealt with his illness as well as anyone could. His name was Ray Sumrall.
Thank you, Malenna, for sharing your heartfelt story. So for some take-home points, the goal of palliative care is to live as well as possible for as long as possible. Remember, you and your family are critical members of the healthcare team, and you can advocate for palliative and supportive approaches to your care. And social workers can help you connect with resources, help you plan for the future. Chaplains can help you find joy, meaning, hope, and love. Palliative care and hospice are not dirty words, but really underused tools to help you achieve your goals of care. And hospice can help honor your goals, avoid hospitals, and spend more time with family in your preferred setting. So thank you so much, and we'll open it up to questions.
Excellent. And thank you so much, everyone, Dr. Kluger, Dr. Sumrall, Dr. Kramer, Sarah Chen, Dr. Ouellette. You guys did an amazing job. This was absolutely wonderful. And we do have some questions. So we'll start with some of the recent ones that we got, because I feel like they kind of piggybacked off of some of the last things that you were talking about with medications. So one of our amazing community members, Helen Metzger, asked if a non-formulary medication is really the best for the patient, is it possible to obtain a waiver to have it covered?
I'm trying to understand a waiver from who? From the pharmaceutical company, or I think it probably depends on the drug. You can also look to see if there's patient assistance programs through the pharmaceutical company. You can see if you have another insurance that might cover it, or you can see what a 90-day supply would cost, or what it would cost to pay out of pocket.
I'm wondering, Dr. Kramer, if they're talking about coverage under hospice care and if there's a waiver to hospice. So those.
I don't think that would be, I mean, I think it would be helpful to ask the hospice agency. Sometimes, every hospice is different. And so some hospice agencies may have a little bit more kind of extra funding, or just, maybe a little bit more flexible with some of these, with some medications. And so it's definitely worth asking, and I think definitely worth interviewing multiple hospice agencies to see if that provides an opening.
Excellent. Did anybody want to add to that before we take another question? Okay. Excellent. Now they're really rolling in. Okay. This next question kind of piggybacks on that. Does hospice take over all medical treatment? Can we still get your LBD medications through their private insurance? I believe you answered that, but just to clarify, go ahead, Dr. Kramer.
Yes, if there is private insurance on top, you can see which ones are covered through the private insurance and which ones hospice would cover.
Absolutely. There's another question here too, that they have not heard of Botox being used for drooling. So at what point is this a good option to consider?
I would say when it's hard to manage secretions, when it's becoming distressful or just interfering with daily function, if it's difficult to leave home because of it, sometimes there's social stigma around that. or if it's trouble swallowing it and sometimes can cause kind of choking or aspiration episodes, those would definitely be a good time. I think it's worth asking your neurologist to see what are my options.
Excellent, thank you. And we've had a few questions about pain management for people with LBD. So if Tylenol doesn't help, someone had asked, is CBD an option, or what are some viable options for pain management with Lewy body dementia?
It's a good question. I think it really depends on what's the source of the pain. If it's arthritis versus muscle cramps versus something else, I think it really depends. CBD, I try to limit that to topical options because oftentimes there can be some cognitive side effects that can potentially make hallucinations or delusions or cause extra sedation. So I think sticking to topical products is what I would recommend. With some of my patients, I've been using something called buprenorphine patch, or called Butrans, Butrans. It is an opioid, but it's a very low dose opioid, one of the safest opioids that has less risk of side effects and less risk of cognitive side effects, less risk of constipation, less risk of addiction than other opioids. So sometimes if we've tried Tylenol, NSAIDs, topical agents, muscle relaxers, neuropathic agents like gabapentin, depending on what the source is, sometimes we'll use Butrans. It's not the first thing we reach for, but sometimes that's been working pretty well and well tolerated.
Excellent, thank you. And then we have a question here about continuing dialysis while someone is on hospice. Is that an option?
It's a good question. It depends on if the reason for the dialysis or the reason for the renal failure is related to the Lewy body dementia. So if there's a pre-existing condition of renal failure requiring dialysis for years, likely that can be covered. But if it's somehow related or a complication of the Lewy body dementia, then it would likely not be covered. And I think that's something definitely you want to be asking the hospice agency in advance, of course, and shopping around if one agency says no.
It sounds like you really can't ask too many questions when you're in that process of interviewing hospice providers to make sure you have clarity. Thank you. Mm-hmm. I really like this question a lot. How do you prompt a conversation with a partner who's the patient who does not think there's anything wrong with him? Physically strong, but declining mentally with memory and cognitive issues, relives grief and loss of the diagnosis over and over when this is approached. Any suggestions?
Start. It sounds like, if I'm hearing the question right, that the fancy word for it is something called anosognosia, which means that people don't have awareness of their condition. And I think this gets to, I guess a theme through all of this, although I don't know if we use the word of practicing with compassion, is that we oftentimes need to prioritize compassion over honesty, or at least over being fully explicit. And so there's a number of situations where you may actually protect a patient from things that we know will be distressing and that aren't going to help them in the long run. There's several situations where that could come up, and that's something, honestly, we're working with your doctor or chaplain or a social worker can really help you in terms of how do you navigate those conversations, which are tough because you see the person in front of you that you've known for decades, and yet in some ways they're not the same person. And so trying to find the best way to help shepherd them through this difficult illness, can be challenging, but I think compassion oftentimes will outweigh an absolute insistence on seeing reality and the truth.
Absolutely. Does anybody want to add anything to that?
From a chaplain's perspective, I think that's part of meeting people where they're at. Saying, okay, so you don't have this condition, but are you as happy as you want to be? Is there anything we can do to improve your quality of life right now? and just allowing them to believe what they believe, but moving forward with their care.
Absolutely. Thank you. Anyone else want to add to that?
I might just add as well, thinking about then how do we support the care partner if they're caring for someone who's having a difficult time adjusting to a diagnosis or cognitively isn't able to kind of internalize a diagnosis, then how do we help support a care partner because they're living with this day to day and trying to figure out how they support their loved one with this illness. And so that might be then a social worker, chaplain, physician, many people can step in at various points and help the care partner then think through what are the current issues that are at play day to day and how do we help problem solve some of that? Or how do we get the care partner their own source of support, whether it's a support group or their own individual therapist, but recognizing that in and of itself, living in that situation must be such a challenge and takes a toll on a care partner. And so we don't want to overlook that as well. We want to keep them at the focus.
Absolutely. Good point. All right. Anyone else before we move on? You guys all have such amazing insight. I don't want to miss anyone. Okay. So we had one quick question here. Can you repeat the name of the patch, please, Dr. Kramer?
Butrans, B-U-T-R-A-N-S.
Butrans. Excellent. Thank you. Here's a question that I think is really, really relevant. We hear this so much at LBDA. My husband's in a memory care facility now for 4 months, and she was called this morning by a nursing supervisor that he had become aggressive. He's hitting people, throwing furniture, etc., and that this is a first. Is this a normal progression? What should she expect? Any advice about medication changes or what to advocate for?
I think the first thing I would say is if there's a sudden change, meaning it's like, a light switch or it's one day to the next, I would definitely check for a urine infection because that's often a cause that's pretty treatable. Usually in Lewy body dementia, decline is slow and progressive. There are changes minute to minute, hour to hour, day to day, but there are more fluctuations and not going from 0 to 100. So if you're seeing a huge change, definitely want to check for an infection to see if there's something treatable there.
Excellent. Anybody else want to add anything? I think that's going to be our last question.
I would just advocate with the facility. It puts the care partner in such a tough role, but that, I'm advocating with the facility to help provide education to speak to exactly what Dr. Kramer was just saying, that sudden changes, we want to check for infection and that this isn't the natural progression of the illness so that the facility can then be better prepared if something like this happens again. They'll be more proactive to be able to check urine or check for infection so that family doesn't find themselves in a really tough situation down the road where the facility has already started to initiate a process where they think that the patient's no longer appropriate for that level of care. And so, just recognizing that, I don't envy any care partners who are having to focus and advocate with facilities, but that really you're the expert and having to, lean on resources available through LBDA to be able to provide that to the facility so they're going to be better prepared to help care for your loved one.
Excellent. I'm going to let that be the last word. Thank you so much, Sarah. And thank you on behalf of LBDA. Thank you to all of our amazing presenters today. You did such an incredible job. And thank you all for your questions, but unfortunately we're out of time. So on behalf of the Lewy Body Dementia Association, I'd like to thank you all for attending and for all of the warmth and response that we've gotten to all of our webinars. A reminder, you're going to receive an email in about a week with the link for the recording to the presentation. And I also had a link link in our chat for where you can locate all of our recordings for all of the webinars so far. I invite you to check our events calendar frequently at the bottom of the homepage on our website for details and registration with upcoming events. And mark your calendars for, oddly, exactly 1 month from today. Our next webinar will be Thursday, September 21st at 2:00 p.m. Eastern Standard Time. Dr. Jim Galvin from our Research Center of Excellence at the University of Miami will be presenting on disease-modifying trials in dementia with Lewy bodies. So a reminder, please take a moment today to complete the survey that you're going to receive at the end of this when you log out. That helps us inform our content in the future. And I hope to see you all again soon. Thank you all so much. And thank you for the amazing team at the International Neuropalliative Care Society. Thank you all. Have a good day.